Good afternoon, and thank you so much. Welcome everyone to the Senate Committee on Health and Human Services. Madam Secretary, please proceed to call the roll.
Senator Lang, Senator Stone, Senator Taylor, Senator Titus, Chair Doniate.
And I'm here, and please mark Senator Lang absent excused. Welcome everyone to the committee meeting today. We have a short meeting today just because there's a lot of things going on this week. And so we do have a brief presentation from the National Conference of State Legislatures. And so just as a few housekeeping items, we do not have any bills to testify on today, but if folks do want to participate in public comment at the end of the meeting, you may do so. We do have a reservation of 2 minutes each per person. And then any of the materials that we talk about today are, of course, available from the legislature's Nellis website. And you can always contact our committee secretary for those resources. So let's go ahead and start with the first presentation. We have with us today Sam, who's the Associate Director of Health for NCSL, and she's here in Carson City. And she also is joined by Catherine, who is a part of NCSL as well, and a few folks, but they're virtual. And so I just as some context as to what they're going to be presenting to us, I asked them, this is pretty standard. We usually invite NCSL just to bring us a nonpartisan agenda of what are things that legislatures are looking for. I did ask them specifically on some bill ideas that, of course, are in conversations with us. And then I think towards the end, they'll talk about Medicaid and some of the federal actions that are currently happening as we're going through these discussions. So please proceed when you're ready.
Wonderful, thank you. And can you hear me okay? Wonderful, and thank you, Chairman Doniate, and thank you for inviting NCSL to speak today. So as you said, my name is Sam Scotty, and I am an Associate Director with the NCSL Healthcare team, and my portfolio relates to healthcare costs, coverage, and access.
Sam, sorry, really quickly, not to interject, but because this is a long presentation, as committee member, if it's okay, as committee members have questions that rise up, if we can stop you just to answer them, because I know there's going to be a lot of content that we're going to go over today.
Yep,
so.
that is correct. So please feel free to interrupt. Thank you.
Okay, please proceed.
Wonderful. So as you mentioned, Chairman, we were invited today to share an overview of recent healthcare policy trends, and we really appreciate being included in the discussion. So as a quick reminder, and I think you all are fairly familiar, NCSL is your membership organization, and so we serve state legislators and legislative staff across the United States. And we do that through several different methods that are here on the slide here. Things like legislative tracking in a variety of databases, policy research to answer questions, technical assistance presentations like our presentation today, and then a myriad of meetings where you can network with your peers. And just one thing that it's always very important that we emphasize, our membership does consist of Republicans and Democrats, and us as NCSL staff are all nonpartisan, and we don't advocate for or against any policy options. So a little bit of context for the discussion today. So here you'll see on the slide, health policy trends A to Z. And NCSL, we have created this infographic based off of the questions that we get from you all, from state legislatures across the United States. So this is an infographic that we hope kind of displays some of the trends that we are hearing based off of questions that we got in 2024. So it's no surprise that Medicaid shows up most frequently in research requests, which is why it's the biggest here, as Medicaid accounts for nearly 30% of total federal and state spending and just below 20% of state-only spending. And as the chairman mentioned, my colleague Catherine Costanza will provide a deep dive into some Medicaid issues later today. We know that healthcare workforce continues to be a significant issue among states as they grapple with shortages and maldistributions of healthcare professions, and I'll talk more about healthcare workforce shortly here. You'll see on the infographic that women's health topics continues to be a priority, including maternal health and reproductive health. Consistent with recent years, substance abuse and behavioral health are also significant topics among state legislatures, and these include topics like opioids, fentanyl, behavioral health care workforce, 988, crisis response, and youth mental health. And then healthcare costs and coverage is also a perennial topic among state legislatures, including commercial insurance, mergers and acquisitions, drug affordability, pharmacy benefit managers, and other topics. And I will also provide a dive into healthcare costs today as well. We've also seen significant focus on public health amid the COVID-19 pandemic, which continues as states address vaccines, violence against healthcare workers, and other related topics. And then a couple other topics to note here that you'll see in the infographic. Emerging trends are healthcare and artificial intelligence. So we're now starting to see a number of states consider how AI is being used in healthcare delivery and how they can both foster innovation while also ensuring safety within healthcare delivery systems. And then a couple other topics of interest, EMS, emergency medical services. We're seeing a lot of states look at the EMS workforce specifically. And then I'll point out long-term care. That's another very hot topic among the states. So as I mentioned, we've been asked here today to cover healthcare trends broadly, and I'll emphasize healthcare being the delivery or process of providing and receiving medical treatment. So what we think of healthcare access, costs, and coverage. So I won't be touching today on health policy trends related to public health or population health, since that is a different discussion. So what I will cover today at a very high level, some trends that we've identified among state legislatures and we've tailored based off of the committee's interest. So I will high level touch on some health workforce trends and then dive into healthcare costs and affordability, including prescription drug access and affordability. And then after my presentation, you'll hear from my colleague, Catherine Costanza, who leads our Medicaid portfolio. And then, of course, we'll close with some additional resources and happy to take any questions. So let's dive right in. So starting with healthcare workforce. At least 45 states, Washington, D.C., and Puerto Rico enacted at least 585 bills related to health workforce topics in 2024. So first here in the infographic, we'll look at by profession. So in 2024, we saw the most legislation addressing various behavioral health professionals. This includes psychologists, psychiatrists, counselors, peer support specialists, and psychiatric aides or technicians. And then next, you'll see primary care on this chart. This includes physicians, nurse practitioners, physician assistants, and this also continues to be a significant trend among state legislatures, with the second most legislation being enacted around primary care. And then on the right-hand side of the slide here, you'll see legislation by type of intervention. So as you know, states are responsible for ensuring safety and quality of care, and being so, licensure and certification is a significant portion of the health workforce bills that we see among states. So this includes things like licensure portability or compacts, and addressing internationally trained health professionals, which is another emerging topic. As you all know, too, states also determine scope of practice for licensed or certified professionals, and we do track scope of practice legislation and maintain a very robust resource on scope of practice. And a couple other just trends to identify related to health workforce that we're seeing. States are looking at improving access to graduate medical education, specifically looking at how Medicaid can be leveraged to fund GME, joining interstate compacts, as I mentioned, and career pathways in healthcare, particularly for K through 12 students. So as I noted on the previous slide, we've seen the most legislation among states enacted related to the behavioral health workforce. About 37% of the U.S. population lives in an area with shortages of psychologists, counselors, and social workers, and we know that nearly 2/3 of those shortage areas are in rural areas. So recognizing this, states have pursued various strategies to bolster the health workforce. First, here you'll see the first bucket of legislation. We see data collection and analysis. So for example, in this bucket, in 2022, Georgia established a behavioral health care workforce database to better understand workforce shortages in their state. So to gather data on workforce shortages, both by area and provider type, and then to better tailor policies specific to providers and in different areas within Georgia. The second bucket is related to recruitment and retention. So last session, we saw Washington create a Health Corps Behavioral Health Scholarship Program and appropriate funds for this program. And it was intended to encourage behavioral health professionals to work in underserved communities. The next bucket is around licensure and certification. So as I mentioned, NCSL tracks various behavioral health related compacts, including psychology, counseling, and social work. We know that at least 22 states have enacted or have enacted legislation to join the Social Work Compact. I believe there's pending legislation currently in Nevada. Another bill to note related to this, in 2023, Illinois enacted legislation to allow for alternative examinations for social work licensure applicants. And then the final bucket here.
Can you explain more about that, by the way, for us, please?
Sure, and happy to and happy to provide more in-depth analysis or bill text. But essentially, for licensure, for social work licensure, they've included alternative examinations, so alternative to the current licensure, social work licensure. And I can get you more details on what exactly that alternative test looks like if that's what you're interested in.
So does that mean that for individuals that graduate from a program, they no longer have to go through the 2 years post for their master's to become a social worker, or what
It's more focused on this specific examination that they need to take then for licensure, as opposed to the amount of training then.
Are they the first state to do this, or are other states that have already implemented non-traditional approaches to testing requirements for social workers?
I could get you the number of states that have done that.
Yeah, I think me and Senator Titus would be interested in that.
Great. Let me write some notes on that. We just actually received a question from another state about alternative pathways, so we're happy to provide that memo to you all. Great. And then finally, for behavioral health providers related to scope of practice, as I mentioned, we track various policy areas on our scope of practice policy resource center, including prior authorization requirements for providers prescribing buprenorphine, licensed professional counselor ability to diagnose, and education required for addiction counselor credentialing. And on the topic of scope of practice, just wanted to highlight again that resource that I mentioned to you all. So on the slide here, this is our scope of practice policy resource center, and it tracks various providers. So you'll see the providers here on the left side of the screen, and across it tracks scope of practice statutes across all 50 states for those provider types. Great. So now I will transition to healthcare costs and affordability. So healthcare spending was 1/5 of the total economy, or $4.5 trillion in 2022, and is anticipated to grow to $7.7 trillion by 2032, outpacing growth in gross domestic product. So you'll see on this chart here on the slide, the growth in healthcare spending from 2001 to 2022, and as I just mentioned, it is anticipated to continue to grow. And related to this data here, total per capita personal healthcare expenditures. Health spending per capita includes spending for all privately and publicly funded healthcare services, like hospital care, physician services, nursing home care, prescription drugs, etc. So that is the trends you're seeing here on the slide. And so we know that a range of factors contribute to healthcare spending. This could include utilization, prevalence of chronic disease, an aging population, innovations in technology and research, and the unit price in services. And while we know all these factors are part of the equation for healthcare costs, some experts and research is showing or attributing this growth in spending largely to increase for prices in services rather than higher utilization of services. So for example, the Healthcare Cost Institute between 2018 and 2022, they found that total healthcare utilization increased by 4%, while prices rose by 14% in that same time period. And noting that while we have seen spending grow across payer type, so Medicaid, Medicare, and commercial payers, per enrollee spending in private insurance has grown most rapidly over the last decade. And with over 65% of Americans being covered by commercial insurance, this can translate to higher out-of-pocket costs for many consumers. So you'll see on this slide that recognizing increasing healthcare costs, we've seen many state legislators consider various options related to commercial healthcare costs and reducing out-of-pocket costs for consumers. So some of these that we've chosen to highlight here include, but are not limited to, creating a cost growth benchmark program, implementing reference-based pricing, leveraging a state premium rate review process to curb rising premiums, assessing healthcare market consolidation and competition, improving transparency in healthcare prices and patient costs, implementing value-based payment arrangements, and evaluating strategies to prevent consumers from receiving costly or surprise medical bills, and safeguarding those struggling with medical debt. So all this to say, there are quite a few different state activities that we've been tracking aimed at lowering commercial healthcare costs. And in the interest of time, I can't go over all of these today, but we're going to dive into just a couple of these state levers that we've identified based off of recent legislative trends and due to the committee's interest. And of course, happy to dive into any of these levers that we don't touch on today, happy to provide follow-up resources. So first, reference-based pricing. So reference-based pricing is a methodology in which a state health purchaser reimburses for a medical services starting at a benchmark or a reference price. And using this methodology, a payer will set a price range or a cap prices for each healthcare service instead of negotiating the price with the provider, and typically using Medicare as a reference price for the payment. So you'll see on this slide here that a handful of states that have tied hospital reimbursement specifically, those reimbursement rates to a Medicare reference point in their state employee health plans, or in the case of Colorado, Nevada, and Washington, in their public option style plans. So you'll note on this chart here on the slide that certain facilities might be exempt from this methodology, and that the reference rate might vary depending on the type of healthcare facility. So for example, in Colorado, certain hospitals are eligible to an adjustment to their reference-based pricing rate based off of what kind of facility they are. So they have a 20% increase to their reference point for essential hospitals, which are considered rural hospitals with less than 25 beds. There is some research out of both Oregon and Montana who have implemented this reference-based pricing methodology, and they've examined the cost savings for their state employee health plan. So Oregon passed legislation capping hospital payments in the state employee health plan to 200% of Medicare rates for in-network care and 185% of Medicare for out-of-network care. A recent peer-reviewed study found that Oregon saved its state employee health plan $107 million in the first 27 months of this program. And in Montana, an independent study estimated that the state employee health plan saved $47 million from fiscal years 2017 to 2019 with reference-based pricing. And recognizing this potential cost savings, Washington, their insurance commissioner just directed the state employee health plan to consider implementing reference-based pricing as well.
So it looks like Senator Lang has a question.
Yes.
Hi, sorry. Could you repeat those numbers again? Because I didn't
Of
have
course.
my page up yet.
Yes, of course, I'm happy to. So in Oregon, they found that this methodology saved the state employee health plan specifically $107 million in the first 27 months of the program. And in Montana, they looked at fiscal years 2017 to 2019, and the state employee health plan saved $47 million.
Senator Titus?
Saving money is all well and good, but did it attribute to good healthcare outcomes and access to care? I mean, so they redefine what they would pay for, and they redefine that they're only, say, not fee for service or how they're based pricing, but that doesn't, was it access the same? Did you have an equal number of employees go to providers, but it costs less? Or in certain situations, we heard testifying on our insurance providers here in the state that the state-based program, my constituents who live in rural Nevada couldn't go to a provider. They weren't on their insurance, on our PED programs. And so it really, the way they signed that contract actually decreased access to care. And it was really a burden. They didn't go because their provider wasn't on, they didn't have a provider on the list in their town. So just because they've saved money, I worry that it actually decreased access to care. So maybe a deeper dive on what that really looks like. I mean, it sounds great, but I worry that something like in Nevada happened where they they were going to undercut the providers, what they were reimbursing them, and so the providers didn't sign up, and so then the employees had to go to Reno or Carson to get care, the state retired employees or employees, and so they didn't get care, or it was out of pocket. Just a question.
Yeah, and maybe perhaps if you can, you referenced that there were some studies that were published in terms of the outcomes, and maybe that, if you can send us that study or reference it, that would be great.
Yep, I would be happy to, and we can look at if any studies have looked at quality and access, and I can say actually, both Oklahoma and South Carolina, their state employee health plans have used this methodology, and through a survey from Georgetown, they spoke to the administrators of the state employee health plan, and they did report that in Oklahoma, 99% of hospitals and 80% of physicians did participate in the state employee health plan network. And in South Carolina, 100% of hospitals and 99% of physicians. So that we can provide a more global look across the states that implement this methodology, but those are just a couple numbers that we're aware of as it relates to access.
And my understanding is that, and maybe I got the state wrong, but I think like it might be Mississippi or something where they used reference-based pricing as a way to control costs because it was. And I think in their scenario, right, and I'm forgetting the entity, but I think it's like the University of Mississippi is like the largest employer for this particular state, and so they leverage reference-based pricing to say, we are the largest employer, and we are only going to pay this amount, take it or leave it, based on the population, as a way to control costs. And so, but anyways, I'm just sharing that because I think that I'm pretty sure it's Mississippi that did that because it actually came up in one of my conversations in one of the NCSL conferences that I went to. So, I mean, if you can look into that for us.
Yes, yeah. More than happy to. And thank you for a question that actually brings me next to my point around considerations around this methodology. So while there are potential cost savings, there are also considerations when deciding if this is an option that a state would want to pursue. So for some examples, some states do note just challenges or the importance of stakeholder engagement, so including both provider engagement and TPA or third-party administrator engagement. So that is the entity that helps design the networks and process claims for these state employee health plans. So that stakeholder engagement would be necessary for ensuring access, as you mentioned. Other considerations noted are how and if reference-based pricing fits within alternative payment models. So it is a fee-for-service model. So if a state or a plan is looking at transitioning to alternative payment models, there are just considerations around how those might fit together. And then the other consideration is around how the state employee health plan is organized, so how they pool benefits for employees. So for example, if they pool all teachers and other government workers in under one plan, as some states do, they might have more market power than states that do not pool their state employee benefits. So just some considerations that we've heard from states around this methodology. But thank you for those follow-up questions, and I will we'll look more into the different research and see if we can get you some more numbers out of those states. So the next lever or bucket that I'll touch on is health system consolidation and competition. So some studies have found that increased health system consolidation could lead to higher provider prices, though providers do also maintain that consolidation might enhance financial stability for certain health facilities, particularly smaller providers in rural areas. And when we say health system consolidation, this includes both consolidation between the same type of organization, so horizontal consolidation, so that might occur between two hospitals, and then vertical consolidation that we see happen across different types of providers, like a hospital acquiring a physician practice. And recognizing the potential link between health system concentration and higher healthcare prices, states are considering a variety of policies within this realm that look at both state authority over mergers and acquisitions, and then also researching the impact of mergers and acquisitions on healthcare access and costs and quality. So the specific policies within this realm include things like state oversight of health mergers and acquisitions, which I'll dive into and which is displayed here on the slide. Health system contracting reform, so reforming what might be considered as anti-competitive contracting terms like non-compete clauses. And then modifying state certificate of need review. So currently at least 35 states, including Nevada, require some form of require hospitals, health systems, physician groups, or private equity firms to notify a certain state agency, like the state attorney general, of certain proposed mergers or acquisitions. However, these state laws vary quite substantially. So, for example, the states in their statute often designate the authorized state entity to receive the transaction notice. So, for example, the state attorney general, the Department of Health, or the Commissioner of Insurance. They often, in statute, in these bills, define what qualifies as a regulated transaction. So, often setting a monetary threshold for what transactions require review. Some states have gone beyond notice requirements to permit the authorized state agency to review the transaction and, in some cases, approve or conditionally approve the transaction. And the state statutes often designate what qualifies as a regulated healthcare entity. For example, this might include a hospital, a provider group, a long-term care facility, or a private equity firm. So, for example, here, New Mexico has chosen only to regulate transactions that involve hospitals and allows the Office of the Superintendent of Insurance to review and to approve or disapprove of the transaction. And on the other hand, Indiana has created a broad definition of healthcare entity to regulate group provider practices, private equity, partnerships, pharmacy benefit managers, and more. And the Indiana law only requires notice to be given to the Attorney General, so they do not have the authority to approve or disapprove. And as I mentioned, Nevada does have does have a statute on the books related to health transaction review, and I'm happy to share. We have a report that compares all state statutes, so you can see, I believe it's notice only that Nevada has, and you can see how you define healthcare entities, what kind of transactions fall under notice, and things like that. So I'd be happy to share that if that's of interest.
Senator Titus.
Thank you. Nevada certainly does have a certificate of need before you can build a new hospital, add stuff. We have to do that process. And so you mentioned briefly certificate of need, but I don't see it really on any of the other states. Do all states have certificate of needs applicant process for healthcare?
Not all
expansion?
states. I think it's around 35, so it's a majority, but not all states have certificate of need review processes. And those laws also vary pretty substantially as far as what type of healthcare facility is required to go through the certificate of need process before opening a new facility or expanding. And so the trends we've seen around certificate of need recently are states, we have not seen recently a state fully repeal a certificate of need, but we have seen them repeal certain facilities within their certificate of need process.
As there's also, in addition to that question, I'm assuming, I know there's been a conversation about private equity moving into healthcare and the purchasing of highly specialized fields that you may only have 1 or 2, 3 different provider groups in the town or city, and private equity just coming in, buying the contracts and buying a whole portion of the market. So I know California was most recently the one that tackled that. Is that also a consideration of certain, of what other states have been looking at in terms of, as this is a growing trend?
Yes, we have seen states look at the role of private equity within healthcare, and specifically or mainly under this umbrella of mergers and acquisitions. So, for example, in the Indiana legislation, they did include private equity as an organization that would fall under the transaction review. So that's one way that we've seen states consider that. Wonderful. So then next, moving on to the final lever within healthcare costs, cost growth benchmarking programs. So a cost growth benchmark ties annual healthcare cost growth to a specific target, often between 2.4% or 3.8% per capita. And state agencies or another authorized authority collect aggregate spending data from both public and private payers to identify cost growth trends and drivers of healthcare spend. And states may implement different strategies within these programs, such as public reporting or financial penalties, to ensure payers and providers meet these cost growth benchmarks. So at least 10 states, including Nevada, have established some sort of cost growth benchmark, either via legislation or executive order. And the first cost growth benchmark program was established by Massachusetts in 2012. And the state set its benchmark based on expected state economic growth, aiming to ensure overall healthcare cost growth does not exceed the growth of the state economy. And so the Massachusetts Health Policy Commission, which operates the state's cost growth benchmark, has the authority to require performance improvement plans for entities with what they deem excessive spending growth. From 2012 to 2017, state spending growth in Massachusetts, state spending growth was lower than both the benchmark and national rate of growth. However, spending has exceeded the benchmark in subsequent years, in Massachusetts specifically. And so these cost growth benchmark programs do look very differently among states, and some noted considerations are which state entity has the power to enforce compliance with this growth benchmark, what tools are there to incentivize compliance, like financial penalties, performance improvement plans, different considerations like that. Should these programs be paired with other cost containment mechanisms like value-based payment programs or incentivizing spending in primary care? That's something that Connecticut does within their cost growth benchmark. They've determined that a certain amount of spending needs to be allocated towards primary care. And then finally, what are best practices for the data collection and reporting of this cost data? And happy to provide any more info on some of those programs. And then finally, related to healthcare costs, we're going to touch on prescription drug access and affordability. And as you all know, this continues to be a priority among state legislatures, and we know that prescription drugs can provide life-saving treatments, though data says that a quarter of adults taking a prescription medication say that they have a hard time paying for them. So in 2024, at least 90 bills were enacted in 35 states related to increasing access to medicines and improving their affordability. And so I will dive into just a couple examples in each of these different buckets here on the slide. So the first trend is related to prices. And here we've seen legislation specifically looking at the prices for prescription drugs. And currently we have 9 states that have a PDAB, or Prescription Drug Affordability Review Board. And this is an independent state agency that reviews the prescription drug costs and sets an upper payment limit for certain prescription drugs. So Minnesota is a state that has a Prescription Drug Affordability Review Board, and recent legislation, they enacted legislation recently to use prices established in the Inflation Reduction Act as a guide for the upper payment limits for prescription drugs. Also related to prescription drug prices, other states are considering if allowing prescription drug importation will lower prices. So for example, Texas passed legislation in 2023 related to wholesale importation, and they enacted a new bill recently adding eligible European suppliers. Next, transitioning to pharmacy benefit managers, or the companies that manage drug costs and coverage networks on behalf of health plans. This has been a perennial priority for state legislatures. So several states have sought protections for independent, non-affiliated pharmacies. And this encompasses, when I say this encompasses a wide variety of strategies that include things like anti-steering to PBM-affiliated pharmacies, providing equal reimbursement to contract pharmacies, and prohibiting increased audits. So an example here is legislators in Kentucky passed a bill requiring network contracts between pharmacies and PBMs to include terms of reimbursement, which a PBM then cannot reduce. Another example here related to PBMs, lawmakers in Louisiana gave authority to the Commissioner of Insurance to develop rules under which PBMs can audit a pharmacy's records and claims instead of allowing PBMs to audit a network pharmacy at will. The next bucket here is related to the 340B program, and lawmakers have been pursuing a host of actions involving the federal 340B program. And so according to the Health Resources and Services Administration, or HRSA, which administers the program, the intent of the 340B program is to increase prescription drug access to underserved populations by allowing certain qualified providers, like a federally qualified community health center or a safety net hospital, to purchase medications at a discounted price from drug manufacturers. So research has shown that the program has, growth in the program has risen steadily since 2018. And several drug manufacturers have now restricted access to 340B priced drugs to contract pharmacies participating in the program. So when the program was first created in the 1990s, the qualified providers could contract with one contract pharmacy to dispense the eligible drugs. Changes around, I think, 2010, changes from the Department of Health and Human Services expanded that, so allowing these qualified providers to contract with more than one pharmacy. And so we have seen increased participation in the program. And again, we have also seen some manufacturers restricting access at certain contract pharmacies. And now we have also seen over 30 states introduce legislation counteracting these restrictions from manufacturers. So that is one trend related to the 340B program. And then the other trend that we're seeing right now related to 340B program among state legislators is related to transparency. So requiring the qualified providers, so the federally qualified community health center or hospital, to publicly report their 340B discounts and funding. And I believe Minnesota most recently published some data from that requirement. I think that is the only state that has so far, but I could look into that.
Can you send us the laws that have been passed to do that? I'm assuming that's because of the worry that there might be some groups or providers that are taking advantage of the 340B programs. I'm assuming that's why states are responding that way.
I believe that, yes, the thought is that they want to better understand the monetary amount that these providers are getting from different discounts. Yes, so happy to send examples of those laws and any related data out of those states. To capture this in my notes, thank you. And then the next bucket related to prescription drug access and affordability is limiting consumer out-of-pocket costs. And so legislation under this bucket has looked at things like caps on the cost of insulin or stipulations around copays that consumers pay for specific prescription drugs. And then the final trend we're seeing here related to prescription drugs is related to GLP-1s, or glucagon-like peptide-1 receptor antagonists, or GLP-1 drugs, which are used in the treatment of type 2 diabetes and in some cases obesity. So currently, at least 13 state Medicaid programs cover certain GLP-1 drugs for obesity treatment, typically though with prior authorization requirements. And where we're seeing legislative action here is around considerations to address coverage of GLP-1s, specifically in Medicaid and state employee health plans. So happy to send those bills too if you'd like.
Let's take a pause because I think does this conclude the slide?
Yes.
Okay.
Yes, this concludes my portion on the healthcare cost side, and then again, my colleague will be following with a presentation as well.
Let's take a pause real quick, and I know a lot of folks probably have questions on the prescription portion. So, Senator Lang.
Thank you. So the federal government did these wonderful rollbacks on prescription drugs for seniors, and then they were taken away in the new administration. Do you see states taking any action to being able to negotiate getting those prices lower in their states?
As far as it would relate to the Medicare coverage piece, we have not, because they likely would potentially be targeting those costs more in Medicaid. So I could look at if they have looked at negotiation within Medicaid, if you'd be interested in that. Happy to look into that.
Senator Stone.
Thank you, Mr. Chair, and thank you for the presentation. I'm kind of fascinated with the PBM legislations that are going on throughout the country. One thing you didn't mention is the rebates that the PBMs are, I'll say, pilfering from patients and insurance companies. And you did talk about steering, which is another issue with PBMs. The PBM bills that you've seen in the past few years, how many are you seeing actually pass into law?
That's a wonderful question. And so the trends I mentioned related to PBMs, so we have a prescription drug database that we actually track introduced through enacted. So we could easily answer that question. I could pull it up and get you that. I will say the majority of bills we see introduced related to prescription drugs in that database are related to PBMs. But the specific number I'm happy to get you. And then we also do see a lot around rebates, white bagging with PBMs, a number of other issues, just highlighting a couple that we've seen out of recent years. But we can very easily pull all those bills from that legislative database if you'd be interested.
I would. And then you talked about these committees that govern the costs of pharmaceuticals. So are these establishing maximum allowable costs that would apply to insurance companies as well as cash-paying customers? Do they actually go in there and actually chop down the average wholesale cost of a drug by 50% and expect a drug company is going to participate? I'm a little confused as to the power that these boards have.
And so their power would be specifically related to state-regulated health plans.
Okay.
So that would include employer-sponsored health plans that are fully insured, not the self-funded employer-sponsored plans, which is a large portion of the employer-sponsored plans. Individual small group marketplace plans, state employee health plans, but that is where their authority would fall.
That makes sense. Thanks a lot.
Senator Titus.
Sorry, you used a term I'm not familiar with, white bagging.
Yes, and I'm happy to get you more. I don't want to, so I do not lead our prescription drug portfolio, I'll be honest, and so I'm happy to get you more information on that specific policy option related to PBMs.
Senator Stone, do you have any idea what white bagging is? He's a pharmacist, that's why I asked.
Ms.
I turned
Cooper?
to my pharmacy friend.
Destiny Cooper, LCB, for the record, nonpartisan staff. Just from a quick search, it looks like white bagging refers to the distribution of specialty medication from a specialty pharmacy or PBMs directly to the physician's office, not directly to the patient.
And then the physician then provides it or sells it out of the office. Okay, thank you. Thank you. Good job, staff.
Yes, thank you, and happy to provide some examples on the white bagging bills that we've tracked.
Thank you. I have two questions, and my Republican colleagues are going to get mad at me, but it's worth asking. Won't be the first time. It's been hard for me to track some of the stuff that's happening nationally. I know that congressional Republicans had in December when they were talking about raising the debt ceiling, they had a PBM reform and they took it out. Is that something that's currently in consideration? Do you guys track what's happening federally? Do you have an update on that, or do you have anything to say about it? Or
We do have colleagues out of our DC office. So the majority of NCSL staff is in our Denver office and follows state policy research. We have a federal team who tracks all federal legislation. So I'd be happy to connect you with them because they are tracking some of that.
And then the last question is, if there's a scenario where the FDA removes their consideration or approval of certain drugs or medications, for example, mifepristone or the measles vaccine, what are states doing in order to essentially address the issue of if the federal government says this drug or this vaccine is no longer approved by us, where does the state come in terms of authorizing such vaccine or drug from being administered?
That is another wonderful question, and I'd be happy to look into that. And we have a team, so our public health, population health team does track a number of state issues related to vaccines. So I'm happy to see if they've seen any legislation related to that.
Thank you.
Mm-hmm.
I think we're proceeding to the next portion, the Medicaid portion.
Yes, and my colleague Catherine Costanza is online via Zoom here. Catherine, can you hear us?
Yes, I can hear and see you. Can everyone hear and see me?
Please proceed.
Excellent. Thank you, Chair Giannate, and the members of the Health and Human Services Committee for having me and for allowing me to join virtually today. As Sam said, my name is Catherine Costanza, and I cover Medicaid program topics here at NCSL. As you can see on the slides, you've asked for information on Medicaid spending trends, cost containment, coverage for immigrant populations, and state actions in response to federal finance reforms. And just to flag that every single one of these topics could fill a separate hour, so we're really going to just be skimming the surface of information here. We have included links throughout the presentation, including NCSL resources as well as third-party resources. And we have additional internal resources on a lot of these topics that we're happy to share if you have any additional follow-up questions as well. So without further ado, let's go ahead and dive in to Medicaid spending trends and information on state spending per person enrolled in the Medicaid program. So broadly, as you heard some of what Sam said earlier, Medicaid and CHIP accounted for almost $900 billion in health expenditures in the most recent fiscal data from fiscal year 2023. And that accounts for that medium blue section of the pie chart there in the bottom left corner. And we know that Medicaid accounts for spending behind private health insurance, which accounted for $1.46 trillion in that green bar, that green section of the chart, and behind Medicare that accounted for over $1 trillion in spending, and that is the dark blue portion of the chart. The purple section accounts for out-of-pocket costs, and the light blue section that's listed there accounts for other third-party payers like the VA. So how much is Medicaid per enrollee spending trending over time? And this leads us to the next slide. And so as you heard from Sam earlier, we know that Medicaid spending is growing, but it has been growing at a slower rate than either private or Medicare spending since the 2000s. So the dark blue bar indicated here represents Medicaid, the rate of Medicaid growth in the 1990s on the far left, the 2000s, the 2010s, and then in the most current decade, the 2020s. So between starting in 2020 and 2020 through 2023, Medicaid per enrollee costs we know have started growing by 2.5%. Which is growth, but it's less than half of the rate of growth of Medicare per enrollee costs and almost 1/3 of private insurance rate of growth. And so how does this look in the states? Well, this particular map shows state Medicaid spending per person or per capita. And the lighter the color on the chart, the lower the spending, and the darker the color, the higher the spending. So states range here from spending as little as $2.5 thousand per person to over $13,000 per person per year. And so Nevada here sits in the lowest quartile as of 2022 expenditure data, which is the most recent Medicaid expenditure data. It tends to, it's kind of a lagging indicator because it takes time for the states and federal government to treat costs. So this is the most recent expenditure data that we have.
Catherine,
So Nevada, yes.
Sorry, we have a question from Senator Taylor when you're done with but you can finish the slide.
Perfect, excellent. Well, I was just going to flag that Nevada has spends an average of about $5,495 per person as listed on the slide. And it's important to note that per person costs vary widely depending on the eligibility group. So I've listed on the slide here the national enrollee median for different populations, including children, adults that are covered outside of the expansion population, individuals with disabilities, and older adults. And as you can see here, children and adults cost less to cover than older adults and individuals with disabilities, which makes sense as older adults and people with disabilities have more complex health needs and simply need more care. And I can answer that question now.
Thank you, Vice Chair Taylor.
Thank you, Chair. Thank you so much. Actually, now I have two questions. So let's stay on the slide that you're on right now. What is expansion? You mentioned that. I see where they fall. Who falls in that category?
Yes. So expansion refers to the group of non-disabled, childless adults that are covered as of the Affordable Care Act when it passed in 2014. That's Medicaid expansion, and that population received enhanced federal matching funds. So states, the federal government pays for 90% of the costs for expansion adults. And non-expansion adults include individuals who are eligible under other pathways, but may not fall into other categories. So that can include sometimes parents and caretaker relatives that are eligible for other types of benefits. It could include individuals who are eligible for a more limited subset of benefits, for instance, like a family planning benefit under Medicaid, which is not the full scope of benefits, but is a limited benefit set. So.
Okay, great, thank you. And I'll go back if we can. Can we go back to the previous slide? I just have a quick question. You talked about the growth and how it differed over each of the decades. Why was it so low in 2010? Any idea around that? Did any data give you any indication?
So I don't know the answer for sure, but I will share what my guess is. So in the 2010s, that is the time period in which the country was experiencing or coming out of the Great Recession. And what we see typically during, we call it Medicaid a counter-cyclical program. And essentially what that means is that when economic conditions are good, Medicaid spending is lower because people have more money, they're more gainfully employed, they have other sources of health insurance coverage, and they may not meet the income eligibility thresholds for Medicaid. However, when state economic conditions change or broader economic conditions change, more people, as they lose income, become eligible for the program. At the exact same time that they become eligible for the program, expenditures increase. Now, what we would expect to see during this is there'd be massive spending growth. But what typically happens is individuals who are otherwise healthy tend to roll onto the Medicaid program. We also saw this during COVID, during the continuous enrollment requirement. So those individuals are not traditionally eligible for Medicaid. They typically use Medicaid temporarily while economic conditions are tough. And because of that, the per capita growth rate looks lower during that time period. It's because the overall risk pool of people who are covered by the program is lower overall. Did that answer your question?
Yes, it really did. Thank you very much. Thank you, Chair.
Senator Titus.
Thank you for the explanation. Thank you for the question, Senator, because that rolls exactly into my question. And I think you've explained it by enrollment, but I wanted to point out, and correct me actually if this is not accurate, but looking at your chart, so going back to the national chart, the next page, correct. And looking at Nevada, looking like we don't spend as much as other states on our enrollees. But I would argue that per what you just explained, we actually had an absolutely huge expansion on our Medicaid enrollees. But I used the argument that just because everybody is enrolled in Medicaid, it's like giving everybody free bus passes, but no more buses. And so they don't actually access the bus because there aren't any. And so for the reason you explain, that we had this huge enrollment in Medicaid during the COVID years, we didn't have any more providers, nor did they actually access care as much. So we have tons of enrollees that never access care. So it looks like, based on the percent of people we have enrolled in Medicaid, that we don't pay as much. But you're basing that figure on the total number of enrollees, right? Versus the money we spent, correct?
Yes, you are correct. So, but that is also a national trend that was happening in all states at the same time that it was happening for Nevada.
Right, because we had, so your argument, or description, not an argument, I apologize, but per your description, a lot of people were enrolled that didn't necessarily go and get health care, nor did they, they thought, oh, I better get some health care. There's a young provider, there's a young group that don't typically access. They didn't have jobs, they enrolled in Medicaid, and they didn't ever access it. And so, but yet they're being used in the head count when you look at total money spent versus head count, and it kind of gives us a false narrative, I think, and actually what Nevada spends per person based on their enrollees.
I understand the point that you're making. I think answering the question of like how Nevada kind of like stacks up compared to other states is a really hard one. I think to your point, you are correct. So during the continuous enrollment requirement, so when COVID went into effect, states received enhanced federal funding to cover, but in exchange for that federal funding, they had to continually enroll everyone who enrolled on the program during the public health emergency. And because of that, exactly to your point, Senator, the people that enrolled in the program tended to be healthier, they tended to use less services. And so nationally and across the board, not just in Nevada, but across the board, we have seen states, we knew that those per capita costs are going to look lower during the pandemic because, as you mentioned, the volume of people is higher, but a fair number of those people were not using services the way that we are used to the average Medicaid enrollee in non-public health emergency times using services. Now, a trend that we are aware of, but we don't really have a good explanation for yet, there's just not good enough data for us to tell what is going on here, is we know that since the pandemic ended, we are hearing that the people who remain on the Medicaid program are using more services or costing more to cover per person than they did before the pandemic. Now, what we don't know is if this is just normal rebalancing. You know, we're just kind of getting back to our normal, whatever the new normal is because of inflation and costs and all of that. For current costs for the enrollee population, or if the enrollees are actually sicker and needing more services or using more high dollar services, but we know that that is a trend that we are seeing.
A follow-up question? So thank you for that, because looking at that spending was from 2022, so that is a very unique time during really a global pandemic era. And based on now in 2025, how often and when can we expect some current data based from 2023 and 2024? How often are you able to get this in a better time? Not necessarily real time, because there's always the billing and all of that, and healthcare, there's a lot of delay sometimes. But when can we see a better comparison than 2022?
That's a great question. So the answer is different if you're asking about your state specifically versus nationally at large. So the reason that we only have, or the most recent data is 2022 data nationally, is because expenditure data lags. The way that Medicaid financing works is that the federal government pays for actual costs of the program. But what that means is you as states and the state program don't know in advance how many people are going to enroll and the services and types of services that they're going to use and the volumes of services that they're going to use. So you don't know in advance what your costs are. And because of that, like the way that financing works is like states and the federal government pay the agency estimated costs. And then after all the claims are paid out, there's a true up period. And then we get the data on what states actually spent. So at the national level, you're not going to get 2025 data until 2026 or 2027. Now, for Nevada as a state, and we'll talk about this a little bit more later, you also have an all-payer claims database that collects data and claims from your Medicaid program. Those will be more point-in-time specific as to what claims are coming through, but you may be able to get more up-to-date information about what claims are coming through in more real time from your APs, from your all-payer claims database. Now, there may be some nuances around that I am not aware of, but I would say for a state-specific perspective, you can look to state-specific resources for potentially more current data, depending on how your payer claims database collects and cleans that data, because this is also pretty messy data.
Yeah, it definitely is. And thank you for all of that, because I have real concerns that our state Medicaid program, I'm a rural physician, and fee-for-service has kept us alive out in the rural areas. Our state is going to a completely managed care model. And so it's not a fee-for-service. So they're hiring insurance companies, managed care. They're getting upfront per enrollee payments. So it is important to know what the average cost is for the individuals that sign up, and so that we can make better contracts with our managed care providers so that I want to make sure the patients get care. And I am concerned about for-profit entities entering into managed care contracts with our state Medicaid program and denying my request for care of a patient and worried about their bottom line. So it's huge issues for me, and I appreciate that.
We have resources on managed care, Medicaid managed care oversight, and prior authorization that we can share out, and we'd be happy to share those resources out. All right. Well, if no further questions, I think we can move on to our, next light and breezy topic, Medicaid cost containment. So with that, sorry, I can't see the slides up on the screen. There we go. So we know now that we've talked about Medicaid spending trends and kind of what some of those broader economic drivers are of program spending, let's take a look at what drives Medicaid costs really within like the state program itself. So there's really 4 buckets here that we're going to be talking about. And the first is enrollment and acuity. So this is literally the number of people enrolled and how sick or healthy that they are. And we've talked a little bit about this just now. So this was a great opportunity to tee up some of this conversation. The next bucket that we talk about is service type and use. And that refers to the types of services that people use, whether it's a hospital outpatient department or a primary care setting, and how many services they use. Are they coming back regularly to the hospital? Are they regularly seeing their primary care doctor? All those types of things. The next category are the payments that states make to providers in their fee-for-service program and to their managed care organizations, and the rates at which they pay for those services. And finally, there are the administrative costs of running the program. And these only account for about 4% of the day-to-day operations, but they can be pretty weighty one-time costs that come up because they can include things like maintaining and upgrading information systems that are used to collect and report program data. And these are really complex, expensive systems. It can cover agency staff, payments to vendors who enroll providers and process claims, and also costs associated with the state Medicaid fraud control units or oversight of fraud, waste, and abuse. And one thing I want to point out is that the populations and services that Medicaid covers specifically impact cost drivers in a way that is unique to the Medicaid program. So for example, we know that Medicaid is the only source of coverage for long-term care like nursing facilities and home and community-based services. Contrary to popular belief, Medicare only covers nursing facility services for a limited duration, usually only 100 days, and has pretty significant limits on home health care and the services they provide. So Medicaid is really nationally the only option there. And according to an analysis from KFF that was published yesterday, Medicaid enrollees who use those long-term services and supports only make up 6% of enrollees, but account for over 30% of Medicaid spending. So those long-term services and supports, which are a unique part of the Medicaid program, are a really big part of the cost drivers related to the Medicaid program. And those are usually older adults, people with disabilities who need those long-term services and supports. So now moving on, what options do states have to think about and manage Medicaid spending? Broadly, state policies to contain costs are going to vary in the resources that are required to implement the policy, whether savings manifest in the short, medium, or long term, and then the magnitude of the impact. How many dollars do these policies actually save over time? So, for example, investing in an all-payer claims database, as Nevada has done, may give the state insight into claims and healthcare trends that are driving costs in the state. But these databases often require upfront financial investment and time for the data collection and analysis before they can be used to help identify those cost trends. And it's important to note that each policy here comes with trade-offs. There are no easy answers in this context. So policies that restrict eligibility, benefits, and payment rates may have immediate short-term budget savings effects, but may worsen health outcomes or provider participation in the Medicaid program in the long term. And again, we've discussed a little bit of some of the concerns here, particularly when we're talking about cutting provider payment rates. And on the other hand, policies that have long-term effects like value-based care or cost commissions may require that initial financial investment, but take a longer time to become operational and can fail if the implementation is inconsistent over time or is cut off partway through. Finally, states not only have cost containment options, but options to increase revenue to cover the costs of the program. And that's in that like green category on the far right side of the slide there. So let's briefly walk through these policy options. I'm just going to flag that there's a universe of information available on each of these, and we can provide more detailed information about a specific policy upon request. So first off, you can contract or shrink the size of your Medicaid program. And the most immediate ways to do that are to restrict eligibility, restrict benefits, or restrict payment rates. And what this does is this functions to just make the Medicaid program smaller. You may cover fewer people, cover fewer services, and pay providers less. And that, again, as we talked about, will shrink the Medicaid budget. Sam, can we go back, please? Thank you. On this policy area, states can also consider options and policies to help individuals transition from Medicaid to private coverage sources instead. So what this has the effect of doing is ensuring that individuals are transitioning to coverage, for instance, in marketplace plans or in employer-sponsored insurance, and are no longer on the Medicaid rolls. States sometimes can do this, for instance, through buy-in programs for working people with disabilities. So buy-in programs provide wraparound benefits, wraparound Medicaid benefits for some things like transportation services or some personal care services, but it doesn't provide all Medicaid benefits for somebody with disabilities who has employer-sponsored insurance but needs a little bit of extra services and coverage to stay employed and stay healthy and stay working. So we've seen, for instance, in 2024, 4 states passed legislation expanding or creating a Medicaid buy-in program. For instance, Indiana passed legislation creating creating a task force for individuals with intellectual and developmental disabilities, including considering a buy-in program for that population. And Maryland expanded the eligibility criteria for their Medicaid buy-in program. So there are options that states have to shrink the scope of benefits that Medicaid provides or help individuals transition to other sources of coverage that are not as heavily focused on state dollars. Next policy bucket is identify cost drivers. So we've heard a little bit about this from Sam through cost commissions or through the examples of that all payer claims database or studies or task forces specifically on Medicaid cost containment. And as you heard from Sam, some of the state cost commissions that are tasked, for instance, with managing cost growth benchmarks may also evaluate Medicaid cost growth data as well. Next, we have that oversight and evaluation category. So this is examining and looking at fraud, waste, and abuse in the program, looking at managed care oversight, so ensuring that rates are set correctly and that the data being collected from managed care organizations is sufficient to ensure that the rate setting process is reflecting accurate data. And this can also include things like vendor and procurement oversight. For instance, procurement of those expensive IT systems and of those other vendors that provide claims processing and all of that. And finally, on that kind of cost containment side, states can also focus on policies to improve outcomes. So healthier people cost less to cover. So value-based care is one way that states can look at paying for higher quality care, for ensuring that providers are controlling costs, but also improving quality. And states have also engaged in benefit evaluation type processes to evaluate whether the benefits that they're covering are yielding cost savings or if they have some beneficial effect for the members that they serve. And finally, we have that maximizing revenue generation. So states are required to fund a portion of Medicaid program costs through the state share. And states make up the majority of that through general fund revenues, but they also have these alternative mechanisms to finance the state share, like provider taxes and transfers from state and local agencies, public expenditures that they can use to maximize the state share. Additionally, the federal matching rate varies for certain populations and services. So states can also look to leverage those enhanced federal matching rates to make sure that if they're covering a particular service and there's an enhanced federal match for that, that they're claiming that that for the highest level of federal match available. Now, one thing to flag, as I'm sure you're aware, and we're going to talk about later, is that the House Budget Committee has proposed changes to provider taxes. So while we know that this is currently a policy option that's available to states, we're aware that there's increased federal oversight and scrutiny, specifically of provider taxes. And so this policy option may look different in the future, depending on what happens in Congress. So with that, we'll briefly run through these examples. We've provided examples from states of all these options. So on contracting program size, Idaho passed a resolution that requests the department implement cost sharing in the Medicaid program and apply for waivers to allow individuals between 100 and 138% of the federal poverty line to choose between Medicaid or marketplace coverage, that subsidized marketplace coverage. So essentially what it does, Arkansas has done this in its Medicaid program, is individuals are covered by Medicaid up to 100% of federal poverty line. When they get to 100%, they have a choice between Medicaid and marketplace plans. And then at 138% and higher, they have the option of enrolling in Medicaid marketplace plans. Additionally, according to the annual KFF Medicaid budget survey, in fiscal year 2024, 8 states decreased their inpatient or outpatient hospital supplemental payments, or both. When it relates to oversight and evaluation, Florida requires its managed care plans to collect and report specific data and measures to the state and requires the agency to use those measures to monitor plan performance. New Jersey revised its State False Claims Act to comply with federal law, but also for the purposes of entitling the state to enhanced recovery in Medicaid fraud cases. On the improving outcomes front, Texas passed legislation establishing a Medicaid clinical initiative evaluation process, which is effective April 1st of this year. And the purpose of that process is to review and analyze clinical initiatives, including an estimate of the number of Medicaid recipients impacted by the initiative and a description of any potential cost savings to the state that could result. And it includes a final report on each initiative. And Utah amended factors that the Medicaid program incorporated into its accountable care organization payment rate structure. And accountable care organizations are a value-based payment and delivery system model. It also directed its state agency to include certain quality measures for hospital quality improvement and authorized the division to adopt different quality standards for rural and specialty hospitals. We've already talked about this, so I won't linger, but Nevada both passed legislation to implement an all-payer claims database in 2021, and in December of 2024, so just 2 months ago, Medicaid cost driver analysis specific to Nevada was published using Medicaid claims data gathered from your all-payer claims database. So you have that to dig into. I was looking at it, and there's a lot of fascinating information in there. And on the maximizing revenue front, Arkansas transferred money from one state fund account to another to basically provide for the state's matching share to draw down federal dollars from Medicaid services provided for breast and cervical cancer screening and treatment. So this was a fund that Arkansas already had in place to pay for cancer screening and treatment services, but they just moved those funds over into the fund that states can use to draw down those federal dollars and account for that federal share. And California passed legislation in 2023 that included the creation of a county behavioral health fund and created a Medi-Cal, the state Medicaid program, provider payment reserve fund, using mechanisms to finance that state share. We also know that states may start leveraging or be thinking about innovation and technology, for instance, artificial intelligence that may be used to streamline some government administrative processes or act as a workforce extender for strapped workforces. These are in early stages, though, and there's a lot of considerations and trade-offs. I am not the AI expert at NCSL, but my colleague Sarah is, and we can provide more information on that if you're interested. Any questions there before we move on to our next dense topic?
Senator Titus.
Thank you very much for all of that. It's a very convoluted pay source, which makes numbers really hard to kind of track down. So I appreciate actually what you are doing. I'd like to go back to the page that you had regarding solutions and covering cost. And it always kind of raises the hair on the back of my neck when we talk about maximizing revenue and increased state revenues. And we may be looking at, we don't know what the federal reimbursement is going to be and all of those. But one of the things that I've always interested in is in Nevada in particular, there's been some information about what employers, what companies in this state have a significant and surprising number of employees that are on the state Medicaid program. And I'm wondering if you do that on a national level, and I'm just going to throw it right out there in Nevada. There was a story run about a company like Amazon, who's a huge company, the percent of their employees that are actually on Medicaid. And so do you have statistics on a national basis about these companies that have huge employees that actually are on Medicaid on a statewide basis? And if so, can we find that?
Yes, we do have some resources related to this particular question. It's been a while since I've looked at them, so I don't recall if they are national or if they're looking at specific states, but I believe that it's a, don't quote me on this, I believe it's a government accountability report from several years ago that did like a survey of like a multi-state survey, so not a national survey, but a multi-state survey, and we can provide you with that information. So we'll provide you with the information that we know is available out there on this particular.
Yeah, well, I'd really appreciate that, specifically in Nevada, what large corporations are in Nevada, and that their employees are then having to have resources such as Medicaid, as opposed to taxpayer and the general tax, raising funds. Real revenue really makes me anxious when we have huge multi-million, billion-dollar corporations here, and I don't want our taxpayers to have to pay for them. Thank you.
Amen.
And I'll just also flag that, obviously increasing state revenue is a polite phrase for something that has a lot of impact in your states. And I know that you as state legislatures hear a lot from your constituents about it. So I know that is a very value-laden process and a value-laden set of policies, just flagging that it is in the menu of policy options there.
Thank you. Any other questions? Senator Lang.
Yeah, and if I could build on that a little bit, because we gave historic funding in the last session to education, but in the past it's been that the support staff have a lot of people on Medicaid because the amount that they're getting paid it qualifies them for Medicare. So if you could look at that too, that'd be great.
Thank you, Senator
I will
Lang.
say we have looked in the past. Oh, I'm so sorry, Chair Donate.
You're good. Proceed.
I believe that we have looked into this question in the past of the number of state public employees that may be covered by the Medicaid program. And at the time that we originally did the request, we're not able to find any sources of information on that in any state or nationally. I will obviously update that information, but just flagging that that information may not exist. We will look and see if it's there, and we'll share it with you if it's there.
Thank you, Catherine. One more question. One of my main interests this session, and perhaps we can bring you for a more in-depth conversation on this, is the Medicaid fraud section. Obviously, there's been consideration of how we can tackle Medicaid fraud for behavioral health providers. I think that's the most prevalent that's happening across the country. I know that there's considerations of how we can empower states can empower Medicaid to be more prospective in terms of looking for Medicaid fraud and when if they detect it, right? For example, if there's a scenario where if a commercial plan that's not Medicaid notices that a provider has been overbilling on purpose, right? And if that provider is doing the same things in Medicaid, how do they communicate between each other with different institutions and reporting? So if you can send us resources, I know we're going to take a deep look into this. And maybe you can come back later on and during session if just specifically talking about targeting Medicaid fraud and abuse. I think that would be helpful for us.
I'd be more than happy to.
I think you're going to keep going.
Great. Yes, and I apologize. I know we are quite over time, so I will do my best to cover this dense topic in a streamlined fashion. So next, we're going to talk about sources of coverage for immigrants. And I'm just going to point out here, immigrant eligibility for Medicaid and other sources of health coverage, I think, is the most complicated topic that I cover. And I say this as a person that covers the Medicaid program. So just please know that there is a universe of information here. And we have, again, more resources on this topic and can dig into it further. But there's probably more than we're going to be able to fully cover in depth today. So first, let's level set on the coverage that states are required to provide under their Medicaid program to immigrants. So states must cover certain qualified non-citizens, that's the phrase used in federal statute, and certain humanitarian immigrants that are designated by Congress from time to time. And some of these categories of immigrants are subject to a 5-year waiting period before they're eligible to receive Medicaid benefits. And there are exceptions to the 5-year waiting period that we're going to talk about here today. Additionally, states are also required to cover emergency services for immigrants, regardless of their legal status. So we know that states have choices to expand coverage to some immigrants who are either within that 5-year waiting period or who do not have legal status. And these are the options kind of listed on the slide here. So we're going to start walking through them step by step with the CHIP options on the left. So under the CHIP, oh, no, sorry, go back to the prior slide, Sam. So the CHIP option on the left, under the CHIP program, states can cover pregnant women for the duration of their pregnancy and for some period postpartum under these two options under the CHIP program. And they can cover pregnant women under these options regardless of their legal status. So the from conception to end of pregnancy option permits states to cover pregnant women for the duration of their pregnancy, and 23 states have adopted this option. And the Health Services Initiative permits states to cover pregnant women regardless of immigration status for some period of time postpartum. And 6 states, including Colorado, effective as of January this year, have adopted this option. Next, in the center column, states have the option to cover, to waive that 5-year period for lawfully residing, again, that's the legal term, children and pregnant women without the 5-year wait. So these are children and pregnant women who are eligible as qualified non-citizens, but they are otherwise subject to that 5-year bar. States can waive the 5-year bar and say you are eligible for coverage. And for this, sorry, I don't have the exact stats on my notes, and I can't read the slide on my talker, but more than 30 states have covered, DC and 3 territories have covered this option for children, and I believe 30 states, DC, and 3 territories have covered this option for pregnant women, but trust the information that's on the slide if I misspoke. And then finally, states can also use state-only funds to cover people who are otherwise ineligible for Medicaid because of their immigration status, either because they are a qualified non-citizen who is subject to that 5-year wait, or because they do not have legal status. So one thing that's important to keep in mind is states can only use some of these options to cover can only use some of these options to cover immigrants without legal status, and can only use some of these options to draw down federal funds. States cannot use federal funds for all of these. So on the next slide, these are the options that states can use to cover immigrants without legal status. And on the next slide, states can receive federal funding for those options, the CHIP options and the lawfully residing waiver. So we know that states have structured this coverage in a lot of different ways, particularly that state-funded coverage, because sustainability and financing is a long-term challenge for these particular programs. So Colorado created the Omni Salud program, and this program was structured as a state-funded pilot marketplace plan. And what it did is it created marketplace subsidies for a marketplace plan that is essentially very similar to the silver option in the state marketplace, and authorized subsidies and appropriated funding for subsidies for families up to 150% of the federal poverty line, regardless of their immigration status. They funded this particular program through savings from the state reinsurance program and a health premium tax. And once they also implemented spending limits on the tax or on this particular program. So the dollars that were appropriated to the fund were all the dollars that were available for the subsidies, and that's specifically to pay for the subsidies. So families that are above that 150% federal poverty line could still purchase the marketplace plan, the marketplace lookalike plan, essentially, but they could not receive subsidies. They had to pay full price for the plan. So once Colorado implemented the program, they paused enrollment several months after the program started in December 2022 because they reached that spending cap. So individuals can still enroll in the plans, but they can't receive subsidization for the plan costs from the state. Utah did something a little different. They extended coverage to children who otherwise weren't eligible under the state's CHIP program, who didn't meet those traditional eligibility requirements. And when they passed it, Utah authorized the agency to implement waiting lists. They included a spending cap at $4.5 million, and they created a sunset provision and data review process to evaluate the program. Broadly, we know that sustainability is a challenge. Illinois is one of the states that covers older adults. So most states that have adopted these state-only funding strategies have predominantly done it for children. Only 2 states have done it for adults or older adults. Illinois, for instance, began covering older adults in 2020, but paused enrollment for this population in 2024 in response to fiscal estimates for its program in excess of $1 billion. So historically, we know that states have used hospital payment tools like disproportionate share hospital payments and uncompensated care pools to pay hospitals for services provided to people without health coverage, which can include individuals who lack health coverage due to their immigration status. For instance, Florida and Texas still use these today, but it's important to note that those particular funding options are strategies to pay hospitals. They don't provide health coverage broadly, and they only cover hospital services. So they don't cover those preventative or downstream services that may help prevent larger costs and care. All right, I'll pause there. Any questions before we move on to the next section? Hearing none. So we're going to,
we have a question from Senator Titus.
Yeah, no, and yeah, someone has, your teammate here has to catch a flight, so we'll keep this. You can run the slides. Thank you very much. So hopefully you're in your office in Denver and you don't have to go anywhere. So real quick, and I apologize, on the states, the coverage for immigrants. It's been a discussion we've had here for a while on presumptive eligibility for moms and better outcomes that we end up at a little investment in prevention maybe save us costs down the road. I'm wondering if any states, I am not a supporter of Medicaid for our illegal immigrants. However, in this state, we do have a lot of guest workers, J-1 visa folks. We have family members who have come here legally that are not citizens, green card workers, etc. But I understand they're not able to get Medicaid because they're not citizens. Do other states have programs for that allow for our guest workers, the green card workers, the J-1 visa workers, family members who are here legally but they're not citizens? Is there an application process or any states covering those under the Medicaid waiver programs?
So just,
I don't know.
Catherine, I think if what I'm assuming Senator Tice is asking is, I think on your slide you have lawful, so it's lawfully present. I think on your slide you only have lawfully residing children and pregnant women. So I think she's asking for, are there other states that have done beyond waiving the 5-year period?
Waiving
for
for
other
everybody,
folks.
not waiting 5 years.
As long as you're here legally.
Right,
Yeah.
as long as you're here legally, you're working, you get hurt, or any of those, do they have programs like that?
I would have to double check. So I believe that the category of individuals that you're talking about qualify as qualified non-citizens, and some of those immigration pathways are subject to the 5-year wait and some are not subject to the 5-year wait. I have a research request with a lovely chart in it that I will send your way to help answer that question. And in the meantime, I know Sam might have to catch a flight, so I can share my slides and take over in case Sam needs to step out.
Yeah, and this is just for folks that they're not applying to become legal immigrants, I mean, or citizens, not staying here 5 years. They literally come and go on a seasonal basis. And so, I'm wondering if there's special categories for that. So, and I know we're out of time. Everybody's out of time, but questions.
Catherine, one more question before you move on to the last slide. I know that the Biden administration just did the rules regulation for DACA recipients to qualify for getting access to the Affordable Care Act marketplace provisions. Are there states that have done that have allowed DACA recipients to qualify for Medicaid that you know of?
I don't know the answer to that question. I would have to check. So the DACA recipients that qualify for Medicaid coverage?
Correct.
I believe that those options are the state-funded options. So, but I will double check and get back to you.
Okay, great. Thank you.
All right. Sorry, I'm going to move along. Get back to our slides. Sorry, we've covered a lot of information here. All light and breezy topics here today. So finally, we're going to chat about federal financing reforms and state activity to respond to those. So first, let's just level set. So we know that the House Budget Committee has proposed a budget that includes some pretty significant Medicaid finance reforms. And that includes changing the federal match rate for the Medicaid expansion population. So that would move from 90% of the federal match rate to the state's base match rate. So for example, in Nevada, that would be, I think it's 60.2% is your state base rate for the expansion population. They have also proposed lowering the floor for the federal match rate. That would apply to these 10 states that are currently at the federal floor, which I don't believe includes Nevada, but otherwise it would essentially say that the federal government doesn't have to pay 50% of Medicaid program costs. As I mentioned earlier, they are considering changes to the way that and to the amount that states can use provider taxes to make up the state share, the percentage, the percentage of dollars that states can collect from their provider taxes to make up the state share. Notably, that does not include options to fund the state share through public expenditures or through local spending in dollars. And we also know that they are also proposing things like a per capita cap in the Medicaid program. So that would essentially cap per enrollee spending. And that could vary depending on the type of enrollee, but we just don't know what type of shape that might take. So essentially the federal government would completely change the way that the Medicaid program is financed and cap per enrollee spending. And that would mean that state dollars could fluctuate. The federal government could pay more when enrollment increases, but when actual per person costs exceed the cap, the state would be responsible for the remaining costs. So with that, we know that, they have also proposed ending the ACA subsidies for the marketplace plans. So the subsidies for the marketplace plans. So we know that states have started to take some action to plan and prepare for federal policy changes, although we imagine that more may be coming soon. So far, we have not seen a lot of enacted legislation yet, but we will be tracking this topic very closely. So first, we know that many states have at various points in time codified the consumer protections in the Affordable Care Act, such as protecting the 10 essential health benefits, annual and lifetime limits, or coverage of certain preventative services. Rhode Island in 2024 passed legislation that requires its insurance commissioner to report to the General Assembly if federal requirements related to annual or lifetime limits under the ACA are repealed, and to make recommendations then regarding the state's insurance market or any action needed by the legislature. Next, we know that some states have started kind of preparing in their budgetary planning processes for federal policy changes. So in 2024, Utah passed legislation that directs their Office of Legislative Fiscal Analyst to analyze the economic and policy risks associated with funding and expansions of the Medicaid program, including specifically the Affordable Care Act Medicaid expansion. Measure the value of that risk and recommend budgetary actions based on that analysis. And finally, we also know that multiple states have what have been called trigger laws that would end Medicaid expansion or otherwise require review or state action to mitigate the loss of federal funds if federal funding for the Affordable Care Act expansion were to change. And we've provided so that is the end of my presentation here today. We've provided additional resources, and we've been keeping a list of the following research requests that we can follow up on and provide you with more information. But our contact information is here. Mine and Sam's is also in the slide deck, and please don't hesitate to reach out anytime. We are really here to serve you as state legislatures and answering any question that you have. And whether it's Medicaid or not, you can reach out and we'll make sure you get to the right person.
Sounds good. Thank you, Catherine. I think we're pretty much good on our questions, and so I think we're good to close this agenda item. It sounds like we have a few follow-ups that you may be able to help us with between you and Sam. I know the presentation was long, but I think it was worthwhile, at least for some of the stuff that some of us are personally working on based on what we've shared. So I'm going to go ahead and close this agenda item, and we're going to move on to the last one, which is public comment. So public comment is open for individuals that would like to participate. Once again, it's for 2 minutes each per person. So is there anyone here in Carson City? Anyone in Las Vegas? And AVH, is there anyone online?
The public line is open and working, but there are no callers at this time.
Thank you so much. Committee members, are there any comments? Thank you. We're going to go ahead and schedule our next meeting. That concludes this meeting. Our next meeting will be Tuesday, February 25th, and we're going to go more of a deep dive into bill presentations and hearings. And so with that, we'll go ahead and the meeting is now officially adjourned. Thank you.